Hello. Today we are taping another episode in our panel discussion on for gray matter. But this discussion, as part of the series, will concentrate on aging in place. We're happy to have with us today three panel members who will help with the discussion. Julia Evans Starr is a director for the Connecticut Legislative Commission on Aging. Guy Tommasi is a marketing director with Lifetime. It's a VNA affiliate, private duty pay. And Barbara Katz is the director for the VNA Community Healthcare. My name is Rich Stecker. With the town of Branford in the Planning and Zoning Department. And we're happy to have this discussion. I'm just going to start off with a few fun facts and definitions and then hand it off to our guests here who have many years of experience on many of the issues with aging in place and with senior issues. Just to get everybody up to date on national data, I've attended a few conferences over the last few years, and there's some interesting figures. Everybody drives from the data. We have, in 2030, 1/5 of the U.S. population will be over 65 years of age, and the population 85 years and older will triple. Every day, you've probably heard this, when 10,000 people reach the age of 65, and we're in the midst of the baby boom silver tsunami, with many who reach that 65 opting for retirement. On the national Connecticut and Branford median age front, and median age is the midpoint for age, nationally it's a much younger country at 37 years of age. The Connecticut median age is 40 years of age, and Branford is one of the elderly municipalities at 47 years of age. I have interest in the whole aging in place because we do a lot of projections and we look to the future with a lot of our plans of development, which is more or less a roadmap for the planning and zoning initiatives and some of the regulations we like to put in place. We have all our reports are on the town website. The administrations, past administrations and present administrations really support a lot of the elderly initiatives in town. Other organizations which are helpful are the Orchard House Senior Daycare Center, which a lot of monies from small cities grant programs have gone into, and also the Senior Center with the director Dagmar Ridgway with a lot of the programs. I won't take up too much time, but I'm just going to jump in a couple of key issues and terms. Social connections, I think, are very important to aging in place. As we all know, some trends that I've heard about include a decrease in the older Americans with disabilities. And that could be, my esteemed panel may say I'm way off base on that, but I think that's true. And a decrease in the older Americans entering traditional skilled nursing homes. The concept of complete streets is very important to us community planners in terms, and Branford is a good example, down in the main town center where we've tried to widen sidewalks, have neck outs, have walkways. Because let's face it, older folks tend to be the ones who get into accidents and break more easily, I think. So, and the healing is difficult. Some other quick terms. Public transportation for older adults. This is a term, and I think we'll follow up with some of the issues, some discussions on public transportation. Has increased 40% over the period. This is the good news, 40% over the period from 2001 to 2009, which reversed the trend. Now, whether or not that's been effective, I don't know. But at least the numbers have shown an increase in the public transportation. Improvements to specialized transportation services in terms of operation and equipment needs to continue to be more efficient with the scarce resources that we have. Some of the other, I think, operation of equipment, we're talking also, internally in the house with the, stair glides, lift-equipped vehicles and the scooters, or jazzy scooters as they are known to be called. Another quick concept, universal design is obviously important for aging in place. Lift appliances, door hardware, reinforced bathroom framing, walk-in tubs. Some of the Brantford planning and zoning actions that we've taken over the past few years, taking advantage of kind of the downturn in the economic crisis. I mean, you know, that the lack of the downtrend in building was putting together some plans, changing some regulations. We put in place some accessory apartment regulation changes, which allow for folks to put the accessory apartments in detached building structures also. We always had it as an in-law apartment internally, but I think we came to the revelation that, you know, it's also makes some sense to put it in for, you know, detached structures. We deed restricted them for long-term rental affordability. And I think we changed, I think this is important, and maybe we changed the definition of family to include a group of not more than 5 persons who need not be related, who are living as a single housekeeping unit and maintaining a common household. So I think the key is here, you know, to follow the demographics, try to be more efficient with the scarce resources, and look to make improvements in some of the issues in terms of housing and building code, electrical code issues. We've required building code. We require ADA updates in terms of new commercial buildings and also residential buildings. So with that, I'll say no more and leave it to the panel to open up with the discussion. They have, as I say, many years of experience with all aspects of aging in place. Julia, will you kick it off for us?
Yeah, well, first, you know, hats off to you, really, from a planning and zoning perspective and in your role for making significant change in your community. And you're really an innovator from the Complete Streets initiative that you're working on, accessory housing, like all that is wonderful, and just want to pat you on the back if I could, and to encourage you to keep that up. You laid out, you did an excellent job talking about some of the dynamics that are taking place. Growing aging population, growing by leaps and bounds. You know, a third of our population, almost a third of our population in Connecticut are baby boomers, people born between 1946 and 1964, and they're graying. So there's the population. You also mentioned what we call this whole rebalancing movement, where the statistics, despite people living longer and despite a growing population of older adults, that more people are choosing to stay in their homes and in their communities, and less folks are going into nursing homes.
What is smaller?
And so with that, the legislature, we're an office of the Connecticut General Assembly, our office on the 5th floor of the state capitol at the Commission on Aging, and they charged us with the Livable Communities Initiative. And I think we'll kind of ease into that, but you laid out many of the components of what really makes a livable community, and we're excited to continue partnering with you. So people staying in their homes, I know that's your business.
Definitely, and I can't agree more with you, Julie, and what's being done, because people do want to stay in their home longer. They want to stay as long as possible. And as they do age in place, we, from a home care perspective, and those who look out for them, have to be prepared to meet those needs. The baby boomers are every day 10,000 are happening. And they're using technology, and they're using equipment today that we, as the provider of those services, have to begin to accommodate. Or they will look elsewhere, or they won't be available to stay in the environment they want to. So on our end, which is the private duty, if you will, sector of home care, we have to stay abreast to that. We have to make accommodations. I was saying earlier to Rich that, you know, via the website, almost 35% of those who are looking for our type of service accessed us through a iPad or an iPod. So the mobile devices are key. So we have to be innovative, and we have to keep on top of that.
Well, visiting nurses, we are the VNA Community Healthcare. We started out as the Brantford VNA 104 years ago. Here in Brantford with one nurse in a horse and buggy.
Oh, wow.
Times have really changed. We still have the picture of her, actually, the first nurse. So now our part of home care, which is called home health care, in contrast to Guy's part, which is home care, is professional rehabilitation at home. As people age, there's a lot of more people living with chronic diseases, not dying from them, but living with them for long, long periods of time. And so visiting nurse services like ours provide nurses to go out into the home to teach people how to care for themselves, to do medical procedures at home, and therapists, physical, occupational, and speech therapists do rehabilitation services in the home. The other two areas we work in a lot to help people stay independent is fall risk. We've had a grant from the Yale School of Medicine for the last 5 years to reduce falls, and we've actually reduced falls by about 80% in people that have been screened and then taken our advice to heart or gotten into an exercise program to improve their balance. And that's really a huge piece of staying independent.
Because a fall can be so catastrophic.
Exactly.
Yeah.
And that's the second biggest reason people end up back in the emergency room
Right.
is falls. So to be able to have this type of a program to help them through that, I mean, think about the second biggest reason they end up back in the emergency room, and with all the attention on keeping people out of the hospital,
Right.
to not address it like the VNA is doing would be actually adding to the problem instead of looking at solutions to keep them home, safe, and not in the emergency room.
So is that where, like, if someone has a fall and they're in the emergency room, maybe they go to a rehab center for a week or two, how many days? And then the VNA helps to make sure that the home is safe for
We
the...
do that.
That's a little part of it.
Part of what we do.
Yeah.
We do a lot of mass screenings. We go to senior housing or senior centers, and we screen people. We screen balance and vision, and there's a lot of factors that go into fall risk. And then we give people rehabilitation services on the back end if they've had an injury.
Do you think it's safe to say in Connecticut we're blessed with a lot of good clearinghouse of information, Yale facilities, you know, where they can screen the mental acuity of people, and we're in good shape that way. I think there was a recent study there in the newspaper that showed that at least you know, there's always comparisons, but it seems like there's a lot of information out there, and I think Guy was that was news to me about made sense of using the electronic media more. You know, be for monitoring and whatever, like things of that sort.
And they're doing that, and at Lifetime Care at Home, you know, we're trying to meet their needs. And when we put, you know, when you take care of the patient or the client, you're really taking care of the whole family.
Right.
There is
That's
all the
point.
family dynamics that go in it.
Right.
So even though the immediate need is to the respective mom or dad or a loved one, there's then the extended family of sons and daughters who may not be able to be in the home all the time, but still want to have some control or some monitoring or some observation. And even though we serve as the conduit between the family and the client, they still want to be able to. So with the technology today and some of the things that we have, that we offer, can do that via a simple screen of whether it be Skyping and observing as well as talking, to medication reminder, to as simple as the social impact where they can go on and read their newspaper or see their kids. So it's I guess having the connectivity of the loved one without actually being there in the home.
And to give a little kudo to the state, I was also talking to a guy. You know, my father had become he had lost his sight. And there's some great programs for the blind,
Visually impaired.
visually impaired. And so that's a great program.
Yeah, and actually, I think you're right. We have a wonderful landscape of service and supports from the state and local perspective.
Right.
The real challenge is navigating those. And how do you
true.
find
Right,
what you need
yeah.
in a timely fashion? And I think a key point of that is what we were discussing earlier, and that is planning in advance for your future
Absolutely.
needs.
Right.
Absolutely. That, and again, as we were talking a little earlier about how many people will see us and say, well, I don't need your services yet.
Right.
And then it becomes the 11th hour, very emotional decision where the best you can do is guide them because at that point they need it. So planning and planning and planning
Say it to the camera.
is planning.
Plan ahead.
Just
Right.
plan ahead. I know there's the thought of, well, that's for older people, but we're all going to get there if we're not there. And having a plan just makes it so much easier if and when, and it's more when, you're going
Right.
to need it.
Right.
Right.
So be prepared.
Our Visiting Nurse Association has a family caregiver support network, which we founded about 10 years ago. And we do consults with family caregivers to help them navigate the system, as you mentioned,
wonderful.
Julie, help them find programs and benefits. And we get at least 3 or 4 panic calls a week. Sometimes people just wander into the building in a panic. My wife is failing or my father's failing. I don't know what to do. Help me.
Yeah.
And I know you do a great deal to educate people, but somehow it's only when the crisis strikes that people are listening.
Right.
It's unfortunate.
And we get calls, as I know, Barbara, you do, and Julie possibly, where the patients will not get discharged, whether it be a hospital or a skilled nursing, without some type of supportive services, home care services specifically.